Greetings and welcome to today's MHA Alumni Webinar, Developments in Minnesota Telemedicine, Lessons from the Field. I'm Sarah Pennebecker, Assistant Director of Alumni Relations at the School of Public Health. Thank you to all alumni, students, and friends of the MHA program who made time to join us live today. Today's webinar is hosted by the MHA Alumni Association and was planned by the MHA Education and Engagement Committee. We are excited to offer this webinar to encourage and provide lifelong learning to both local and distance alumni, and we plan to offer more webinars in the future as part of an ongoing series. Before we get started, I would like to go over a few items so you know how to participate in today's event. If you join the presentation listening using your computer speaker systems and you would prefer to listen over the telephone, just select telephone in the audio panel of your GoToWebinar panel and the dial-in information will be displayed. If you experience audio difficulties while listening by your computer speakers, this can be caused by having multiple software applications open, which can use up your computer's bandwidth and affect network performance. Listening in on a wireless signal may affect performance as well. Feel free to close any unnecessary applications on your computer. Questions are welcome and you may submit them at any time. Please type in your questions in the questions panel on the right-hand side of your screen under Q&A. We'll be monitoring questions along the way, so please submit your questions or comments at any time. Please do not use the chat function as we may miss your question. So once again, please use the Q&A so we can make sure we can answer your question. And now for our webinar on telemedicine. Our presenters today are Dr. Peter Huckfeldt, Jack Dressen, and Dr. Jerome Siy. Dr. Huckfeldt is an assistant professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. His research investigates the organization and payment of healthcare providers and the effects of delivery interventions targeting more vulnerable populations. His current project investigates the effects of an intensive lifestyle intervention for type 2 diabetes on economic outcomes, the organization of hospitals and post-acute care providers, and the effects of Medicare managed care plans on healthcare use. Jack Dressen is the Administrative Director at Hospital Medicine at HealthPartners. He joined HealthPartners as an Administrative Fellow after graduating from the University of Minnesota's MHA program in 2014. Jack served as the program manager for telemedicine prior to moving into his current role with the hospital medicine team. Jack has leadership responsibilities for an adult and pediatric hospital practice that serves 10 hospitals in the Twin Cities metro and surrounding areas, including western Wisconsin. Jerome Siy, MD, is the Division Medical Director for Hospital Specialties at HealthPartners and a practicing hospitalist. He is also an adjunct assistant professor of medicine for the University of Minnesota Med School. He joined HealthPartners in 2000 as a hospitalist. In 2006, he became chief of hospital medicine at Regions Hospital and then department chair in 2010, overseeing and developing the HealthPartners adult and pediatric hospital medicine program at 10 hospitals in the Twin Cities metro area and St. Croix Valley in western Wisconsin. Jerome joined the University of Minnesota's executive MHA program, which he will complete in January 2020. Thank you, and now I'll turn the webinar over to you.
Hi, everyone. So I am Peter Huckfeldt. Thank you all for attending our webinar today on telemedicine use in Minnesota. So I'll just start by just noting, I'm sure everyone who is attending this webinar is aware of this, but telemedicine is increasingly becoming an important way of how healthcare is delivered in Minnesota, but also in the US and in the world. So a broad definition of telemedicine is that it is like the exchange of medical information using electronic communications. But of course, if we we base telemedicine on this definition, this telemedicine would have been widely used in the 20th century because, of course, people have been talking about healthcare issues on the phone for many years. But so when we're thinking about telemedicine, we're really thinking about uses of telecommunication technology that have sort of use of utilizing expanded broadband access and improvements in online video conferencing to make remote care of patients more and more possible. So if you just think about how much video chat platforms have improved in performance and increased in use in the past 10 years, that sort of parallels the increased use of telemedicine. And so when we think about telemedicine, there are really a number of modalities that are used in telemedicine. So this could include two-way video services, smartphone applications, as well as just more, old-fashioned teleconference and email capabilities. And really a varied set of healthcare services are provided via telemedicine. So this ranges from primary care, remote patient monitoring, behavioral health, as well as specialty consults. So really we think about telemedicine as having a great deal of promise at improving healthcare. So on the one hand, telemedicine may expand access to healthcare. So for example, in places with fewer providers, for example, I'm thinking about like rural areas where hospitals and clinics may be closing or a great distance away, telemedicine may expand access to healthcare. And at the same time, telemedicine may improve the efficiency of healthcare. So this could happen by supplanting more costly in-person services when they're not necessary, or by increasing access, providers may catch important health conditions faster. So in all of these ways, telemedicine really has the potential to improve healthcare. So this figure is from a paper that I will be discussing shortly, but it shows rates of telemedicine use in Minnesota between 2010 and 2015. And it shows the rates of users per 10,000 insurance enrollees overall and across different sources of insurance. And I think the key takeaway from this figure is that use of telemedicine has really grown in the past decade. So in 2010, only 26 out of each 10,000 insurance enrollees in Minnesota received any telemedicine visit. And by 2015, this increased to 113 enrollees per 10,000 enrollees. So the overall rate is still somewhat low, but the growth is really striking. So what's really exciting to me as a faculty member in the University of Minnesota School of Public Health is that our students and alumni are really pioneers and innovators in telemedicine provision. So a few examples include Gianni Yu, who is a PhD student and PhD candidate in the Health Policy and Management Division. And she is partnering with the Minnesota Department of Health to investigate telemedicine use in the state. And she's doing that using the Minnesota All-Payer Claims Database, which includes healthcare utilization for a large majority of insurance enrollees in Minnesota. Another example is Julie Hooley, who is an important leader in a telestroke initiative that is being implemented by Fairview and mHealth. And then another example are my co-presenters today, Jack Dressen and Jerome Siy, who are implementing a telehospital medicine program for critical access hospitals through HealthPartners. And so these are a few examples. I would note that we have other alumni and current students that are involved in other telemedicine activities around the state, so including at Avera Health and the Minneapolis VA. And so this is really just a sampling of the work that is being done by our students and alumni. So what we're going to do in the webinar today is really go through some of the key findings that are coming out of the research and the ongoing telemedicine initiatives that are being led by our current students and alumni. So here's just an outline of the talk today. So I'm going to start by describing some work that I did with a PhD student and other co-authors that just kind of provides an overview of telemedicine use in Minnesota to sort of set the stage. I will then talk about some research being done that looks at the effects of direct-to-consumer telemedicine. And then we'll go through a couple of case studies where our current students and alumni are implementing telemedicine initiatives around the state. So to start with this overview of telemedicine use in Minnesota, let's just start by just motivating why Minnesota is an interesting place to study in terms of telemedicine innovation. So to start, Minnesota really has a state policy environment that is really ripe for encouraging innovative uses of telemedicine. So quite early on, relative to other states, Minnesota's Medicaid program established payment parity, or paying the same rate, for mental health care that was provided in person and remotely via like a teleconference. So that was all the way back in 2006. More recently, the Minnesota Telemedicine Act was implemented and passed. And so this legislation established payment parity, first for Medicaid payment, but also for commercial insurance payments for a wider range of services. So beyond the policy environment, I think Minnesota is also interesting because it encompasses both urban areas and really remote rural areas. And these two types of locations really have differing unmet healthcare needs that pose really differing opportunities from telemedicine. And then I think a third point is just that the healthcare providers in Minnesota have been innovators across different parts of healthcare, but certainly in telemedicine. And an important example of this is that Minnesota providers are really on the forefront of establishing patient-initiated direct-to-consumer telemedicine visits. So, with this motivation, we embarked on some research to really study how telemedicine was being used in Minnesota. And really, when we started this work, statewide use of telemedicine was largely unknown. And this was in part due to a lack of data at the population level. So Gianni Yu, who is a PhD candidate here, led a collaboration with the Minnesota Department of Health to analyze the Minnesota All-Payer Claims Database. So this really valuable data set includes healthcare claims for 89% of Minnesotans with healthcare coverage. So using these data, we could look at telemedicine use across a broad range of populations. So this paper came out in Health Affairs in December of 2018, so just a couple months ago. And Gianni Yu is a leader, and then the other authors were Pamela Mink and Stefan Gildemeister at the Minnesota Department of Health, and Gene Abraham, who's also at, of course, at the University of Minnesota. So this was really a descriptive paper that sought to answer a number of questions related to how telemedicine is being used in Minnesota. And so we were interested in looking at, what types of healthcare providers are delivering telemedicine, what modes of telemedicine are being provided in Minnesota. So we focused in large part on this patient-initiated direct-to-consumer telemedicine. We also looked at these kind of real-time provider-initiated consultations. So I think you could think of the first, the direct-to-consumer telemedicine. This is when a patient is at their house, they have a healthcare concern, and they can initiate a conversation with a physician or a nurse practitioner to address their concern. The real-time provider-initiated consultations take the form of, for example, a patient in a rural area goes to a clinic, and then, for example, a nurse may establish a consultation with a remote specialist to address a healthcare concern. There are other types of telemedicine that exist, for example, remote patient monitoring and sort of asynchronous telemedicine. For example, when like teledermatology, when a dermatologist looks at a lab and provides a diagnosis, but it doesn't happen in real time. A third question that we tackled in this research was how does the type of telemedicine being used vary by insurance coverage? And this really reflects that insurance coverage of telemedicine varies considerably across Medicaid, Medicare, and private insurers. And then finally, we were interested in how telemedicine use differs between patients in urban areas versus rural areas when the sort of unmet needs may differ. So the first finding that I showed in a prior slide was just that telemedicine use is really growing, but overall use is still low. So, when we look at total telemedicine encounters and visits, these were like 10,000 visits in 2010 in Minnesota, and these increased to over 80,000 by 2015. But when you think about the population of the state, this is still a relatively low rate. And we found, so again, we focused primarily on these DTC patient-initiated visits and real-time provider-initiated visits, and both really grew substantially over this period, although the direct-to-consumer visits really do form the majority of telemedicine use in Minnesota. So next we looked at telemedicine providers in Minnesota. So this pie chart shows the distribution of providers across telemedicine visits in 2015. And I think a key finding is that, the plurality of providers are actually nurse practitioners and not physicians. And then when we look within physicians, the majority of physician telemedicine visits were provided by psychiatrists. So next we looked at the use of direct-to-consumer versus provider-initiated telemedicine and how this varied by insurance coverage, the type of provider, and physician specialties. So when we look at direct-to-consumer telemedicine visits, the vast majority of these visits were provided to commercially insured patients. And when we look at provider-initiated visits, these really were distributed across different types of public and private health insurance coverage. Then when we look at the breakdown of providers providing either DTC or provider-initiated services, what we find is that the direct-to-consumer services are really being provided by primarily nurse practitioners, while the provider-initiated services are predominantly provided by physicians. Then finally, if we look at just telemedicine visits that were provided by physicians, we find that the direct-to-consumer visits were primarily provided by family medicine, while the provider-initiated visits were provided by mostly psychiatrists. And so I think this sort of reflects the fact that the direct-to-consumer visits are often for more kind of primary care-oriented conditions, such as sinusitis. So next, we wanted to look at the use of telemedicine in metro and non-metropolitan areas in Minnesota. So this figure comes from the appendix of our Health Affairs paper, and it just shows the rate of telemedicine use per 10,000 insurance enrollees separately by health insurance coverage. So what you find here is that, like, overall, the story kind of differs depending on the type of health insurance you're looking at. So for both Medicare and Medicaid, we find higher rates of telemedicine use in the non-metropolitan areas, among patients in non-metropolitan areas, and this really reflects the coverage rules in these areas. But in contrast, if you look at commercially enrolled patients, we find higher rates of telemedicine use in the urban metropolitan areas. So then we broke down the use of telemedicine in metro and non-metro areas. And so I think an interesting thing is that, when we look at the payers of telemedicine visit in the metropolitan areas, this is really mostly being paid for by commercial insurers, while in the non-metropolitan areas, this is really a mix of public and private insurers. And then if we look at the type of telemedicine and who provided it separately by metropolitan status, the metropolitan areas, most telemedicine are DTC services from NPs. And then in the non-metro areas, we're seeing much more provider-initiated services that are being provided by physicians. So just to summarize our findings, in Minnesota, we're finding high growth in telemedicine use, but the overall use really remains at low rates. And telemedicine is really meeting different needs in urban and rural areas. So our results suggest that in metropolitan areas, what telemedicine is doing is mostly improving the accessibility of primary care. While in rural areas, what telemedicine is doing is expanding access to specialty care, and in particular, expanding access to mental health services. So I think there are some interesting further questions on this research. So, the patterns of use we are finding are not surprisingly related to health insurance coverage. So it would be interesting to know, what would happen if Medicaid, gave access to direct-to-consumer services. Medicaid enrollees may also benefit from these types of this type of coverage. And another interesting point is that there have been some policy changes in recent years that have granted flexibility to Medicare Advantage plans and accountable care organizations. And so these entities are facing accountability on resource use and patient outcomes. And so they may have a strong incentive to use telemedicine in an innovative way, and they may be sort of an interesting sort of context to study going forward. Okay, so now I'm going to talk about a couple of different case studies. The first is some research looking at the effects of direct-to-consumer telemedicine on cost and quality. So this is ongoing work by Jiani Yu. So she was the lead author in the prior study as well. So she's a PhD candidate here. And as we saw in the prior paper, the majority of telemedicine visits among commercially insured individuals in Minnesota are these patient-initiated direct-to-consumer telemedicine visits. So DTC telemedicine really is different from other types of telemedicine that are provided in Minnesota. So for one, they're provided in a patient's home often. They're often delivered by a third-party vendor as opposed to the sort of patient's primary provider. And they really take a wide range of forms. So there are audio-only DTC telemedicine visits. There are web apps that are used, and in some cases this is video conferencing. And they're really mostly used for primary care conditions. So the question that Jiani is tackling in her dissertation research is whether DTC visits are better than in-person visits for these kinds of conditions. So potential benefits of DTC visits is that they may lead to better adherence to clinical protocols because the providers of DTC are really following these protocols as they're treating patients' health concerns. Another benefit is that through their great convenience, it may improve access to primary care, especially as we're seeing primary care providers facing, being overbooked and there being long wait times to obtain visits. And to the extent that these DTC visits substitute for other in-person visits, this could lead to sort of fewer unnecessary in-person visits and services and lower healthcare spending. But there may be potential harms as well. So one question is in-person patient-to-physician communication better than this type of virtual communication. If these services always precede a follow-up visit in person, then it may just be that these services just increase spending. And the convenience of these services may lead to unnecessary visits. So to date, really the evidence is mixed on this, and it's mostly correlational.
Dr. Huckfeldt, we have a question online.
Sure.
The question is, are they planning to review the payer and usage data post-2015? It would be interesting to see the impact the 2015 Telemedicine Act had on insurance submissions.
That is a great question, and that is actually one of the chapters of Gianni's dissertation. So stay tuned for those results.
Thank you.
So I guess the one last point I just want to make is that there is really mixed findings on the effects of these DTC visits, and a lot of the effects are really correlational, sort of not measuring the causal effect of the visits, but really just looking at the correlation of these visits with patient outcomes and healthcare use. So what Gianni is doing is she is really trying to estimate the causal effect of a direct-to-consumer visit on healthcare use and outcomes. And so what she's doing is she's leveraging a really interesting natural experiment. So certain Minnesota insurers were early adopters of direct-to-consumer telemedicine. So what she does is she's comparing changes in treatment for urinary tract infections among the insurers that were early adopters of DTC versus insurers that did not have or did not offer DTC. And she focused on three types of measures. So she looks at how these visits affected the initial treatment quality. So do we see that DTC visits led to fewer inappropriate antibiotics, or there are fewer unnecessary lab tests? Then she's looking at, did this lead to more follow-up in-person visits relative to an initial in-person visit? And then finally, she's looking at whether these DTC visits substitute for in-person visits versus just completely just supplementing in-person visits. So the results, this analysis is still underway, but I urge you all to keep your ear to the ground, because I think this will be a very impactful study when the results come out. So the last thing I want to talk about in my segment is a really interesting initiative focusing on telestroke in Fairview and mHealth. So just to motivate this, so when patients are presenting with stroke symptoms, quick diagnosis and treatment is really critical, and so speed is of the essence. So one issue is that stroke symptoms really range in presentation. So it could be that someone is having a little bit of difficulty speaking, or it could be that half of their body is paralyzed. And so it's really important, given the range of symptoms, that they need an immediate physical exam. And also imaging, and then to have that imaging be interpreted by a stroke specialist, and to determine what is the best treatment for their presentation. And in particular, it's really important to triage whether someone needs thrombolysis to dissolve a clot. So access to stroke care really could be delayed under different scenarios. It could be that a patient lives in a rural area, and in that rural area there are fewer stroke specialists to examine their lab results and to examine their symptoms. Alternatively, a patient could reside in an urban area and present with stroke symptoms, but it could be that they arrive at a hospital or clinic after hours, or they may go to a site that doesn't have a stroke specialist. And both of these scenarios could lead to a delay in diagnosis and treatment. So Julie Hooley, who is an MHA grad from 2018 from our executive MHA program, has been taking a leading role in implementing this Fairview mHealth telestroke program. So the goal of this program is to provide quick access to patients who are with emergent strokes to fellowship-trained stroke or neurocritical care specialists. So one really interesting thing about this program is that they're piloting it in both metro area hospitals, so Southdale and Edina, and also Ridges and Burnsville, which is a little further out, but still part of the Twin Cities metropolitan area. But they're also testing it in a rural hospital in Grand Rapids in northern Minnesota. And so the infrastructure with this program, they have sort of stroke navigation tools in the EMR. And then they have a stroke cart that facilitates this remote specialist evaluation. And then on top of that, they do have different types of staff resources like program coordinators that are helping run the program across their various sites. So I took this picture from a mHealth blog about the program, but this sort of shows like what a stroke cart looks like. So this patient is being consulted remotely by a stroke specialist. So really this program has shown great promise. In one of their pilot locations, they found that prior to the telestroke program, there was a 61-minute wait from an initial stroke code to having a neurologist at the patient's bedside. During the telestroke pilot, they reduced this time to 14 minutes on average, and that was relative to a goal of reducing this to 20 minutes. So this was really just, I think, a very successful first step in reducing stroke treatment times. And due to this success, they're expanding this program more widely. So their goal is to have 24/7 access to these types of emergency telestroke consults at all Fairview and Healthies clinics and hospitals. And in addition, they're expanding this to a few non-Fairview hospitals. And then they're also hoping to implement sort of similar management tools for inpatient telestroke, so not the emergent, but the sort of more management part of stroke care in Fairview hospitals this year. Okay, so thank you very much. I'm going to hand it over to Jack and Jerome.
Great. Thanks, Dr. Huckfeldt. So, hi, this is Jack Dressen, and before we get into what we're doing at HealthPartners, I just wanted to ground people in our hospital medicine practice. So Jerome and I have responsibility for our 12 practice locations that are located in the Minneapolis metro area and then out in western Wisconsin as well as western Minnesota. We have a diverse practice. We have about 120 providers in our practice covering different services from straight general medicine to academic services at Regions, but also med-ped services at Children's of Minnesota, both the St. Paul and Minneapolis campuses, and then telemedicine. And so that's what we're here to talk a little bit about today.
One of my recent passions has really been around rural health, and you'll see here several somewhat alarming headlines that have come out in the recent years. I actually follow University of North Carolina that has a health services center that studies rural care, and that number of 93 rural hospital closures has actually changed as of yesterday. It went up to 97 rural hospital closures since 2010. On the left, for those of you in Minnesota may have seen some recent publications on obstetric care in Minnesota. We have had since 2000 to 2015, there have been 15 hospitals that have eliminated obstetric care, all in rural areas. That represents 38% reduction, which is among the worst in the country, actually. And so when we think about rural care, we really want to think about how we can maintain access to care in these populations, but also to help these communities continue to thrive. And all of this work really stemmed from the results of all that on our providers. When we first were approached to help staff and see patients in our community hospitals out in western Wisconsin, it was because our physicians there were really starting to burn out. Gone are the days where our family doctor could do everything. They were the emergency room, they were the obstetrician, they were the primary care doctor, they were the nursing home doctor, and they still had to be able to be available 24/7, expect to have a family at home and be able to make it back into clinic the following day. And as you know, although 97% of our land mass is non-urban, a whole 20% live there, and yet we don't have enough clinicians who can live in these communities to take care of our rural communities. And so we were called upon to find a way, an affordable way, to care for our communities. I always like this image. On the left, you'll see an old Norman Rockwell painting where he depicts the small-town family doctor, and he's there examining his doll. And on the right, you'll see a juxtaposition of one of our telemedicine doctors. This is Dr. Platt, who was finishing a shift in his home when his daughter woke up and came up and sat right on his desk, and he sent me this photo that his wife took. And it immediately reminded me of the Norman Rockwell painting and how that really has made a change in medicine as it's delivered today. But when I looked back and gave a different presentation on telemedicine, I recognized that this was predicted way back. If any of you on this call remember the Jetsons from the days of yore, they were actually providing telemedicine even back then.
So Jerome outlined a little bit of the burning platform that we were given by our rural hospitals, and so as we went down the path of exploring telemedicine, we established some program principles for us to be our guiding force, if you will. So knowing that keeping care in the community is important not only for our patients, it's where they want to be cared for, but it's also about keeping our hospitals healthy from a financial and sustainability perspective. As Jerome talked a little bit about the sustainability and preserving of a sustainable practice for our local providers, knowing that if we can create a sustainable practice for the local family physicians, that we may be able to see some success in recruitment and retention down the line. And then, of course, keeping an eye towards affordability, knowing that it's not possible to, or not financially feasible to continue to pay call pay at these rural hospitals. And so how do we use a somewhat expensive resource in the physician and use it in a more efficient way to make sure that patients in all of these communities have access to a provider around the clock. And so about 17 months ago, we went live with our telemedicine program, first covering Hudson, Westfields, Amory, and St. Croix Falls in western Wisconsin, and then more recently covering Hutchinson Health, a portion of their nights. Our program runs from 6 p.m. to 8 a.m. And spans 131 miles from Minnesota to Wisconsin. As Dr. Huckfeldt was mentioning, telemedicine comes in many forms, and so we always feel it's important to ground us in what when Jerome and I talk about telemedicine, what we are actually talking about. And so our workflow looks something like this. You present in the ED at one of your community hospital. You have an evaluation by the ED provider at that time. You go through an evaluation, a workup, and the ED provider will say, let's keep you in the hospital tonight. And at that point, they'd have a phone call with the telemedicine provider who's covering that evening. And then, so the sign-out occurs at that point. Patients rolled down to their room, settled in by the nurse who's on that night, or one of the nursing staff. And then the nurse rolls the cart into the room to start a live audio and video conversation with the telemedicine provider. They go through a complete workup, and then at that point, as the conversation concludes, the telemedicine provider can complete the admission encounter. And then they remain available throughout the night, and then in the morning, your daytime provider will come in and assume your care. So as we started this work, we knew that it was important for us to keep an eye towards the quality of the care that we're providing, but also try and help further the conversation about adoption of telemedicine. And so we were lucky enough to get a grant and then start a research project as we started our program. So a huge thank you to our team at the HealthPartners Research Institute. I'll name them. Jennifer, Jeanette, Megan, and Brian have been just great partners through this process. So just a little recap of what we've done to date. So we've provided about 7,200 hours of coverage across our 4 sites. We've conducted 1,700 patient admissions during that time. And as I talked about a little bit earlier, from a recruitment and retention perspective, we've been able to attribute 4 new clinicians joining practices in one of the communities that we cover because of the decreased call responsibilities that they would have. We also, in the first 90 days, wanted to look at the patient experience. So that, again, the program was just getting off the ground, but we were able to get surveys out to just over 200 patients who had a telemedicine encounter during their hospital stay, and wanted to look to them to see how would they adopt this innovation, knowing that that this would be new for a lot of our patients and a majority of our patients who are older than 55, and so knowing that adoption of technology may not be in their wheelhouse. But as you'll see from our survey results, we're actually quite pleased with how with the feedback that we got. So identifying that they were able to establish a relationship with their physician 96% of the time by saying that the telemedicine doctor treated them with courtesy and respect. That they were able to hear and understand the care that they were getting 90% of the time. That they saw this as a good thing and that it wasn't detrimental to their experience in the hospital. And then we also threw in this question about, if you think about your community and communities like yours, is this a feasible way of getting care, and is it something that you might expect people in neighboring towns to accept? And we were really pleased to see an 85% favorable response rate on that. We also wanted to keep an eye on how our nursing staff, our nursing partners, and then our physicians were viewing this telemedicine and this innovation. And so seeing really nice response rates. Our physicians are loving this and engaged in this. Talking about how were they able to assess the patient and make a connection with them 93% of the time. And then if you think about, we put it on a scale from 0 to 10, worst care possible, the best care possible, how do they feel, their perception, and a majority of them saying that they feel this is ranging in towards the spectrum of best care possible. And then, again, looking at that, would you recommend this to other like facilities? So that was really what we looked at from an experience perspective. And Jerome's going to go into a little bit more of the statistics around what we've observed.
Well, I don't know how much detail I'll go into statistics. I was joking earlier that my professor, Gene Abraham, would be disappointed that I wouldn't be able to do this a little bit better. But on this first slide, you'll see that we looked at our population of nighttime admissions that were done in 3 of our hospitals. We had more access to our HealthPartners hospitals than those that were not HealthPartners. So we looked at over 1,600 admissions pre-telemedicine and 1,800 admissions that were post-telemedicine. And we first looked at their demographics, and we found that both of these populations were not considerably different, with the exception of the payer mix. You'll also note that in those payer mix populations, they are predominantly government insured. There was a few who had missing details, but you will see that primarily these individuals coming in at night are Medicare and Medicaid. So I do want to just caution everybody that these are all preliminary data. It actually was quite complicated to make sure we had the right sets of patients to compare. But as far as we know, this is one of the first studies that looks at outcomes for telemedicine, particularly as hospitalists. And so we looked at 30-day readmissions, transfers to regions, which is one of our main transfer sites, but we wanted to look at all transfers as well, so you'll see their transfers to any hospital. We looked at discharge, post-discharge complications, 30-day mortality. What's not on here is length of stay, but in all of these categories, you'll see we actually looked for non-inferiority. And so on the right, you'll see the adjusted odds ratios. Those were adjusted for payer, because as I mentioned earlier, there was some difference in payer mix. And we had a non-inferiority set at 10%. And so you'll see that we did not find an odds ratio that that would demonstrate inferiority at all in our post-telemedicine population. So we really think that this is an opportunity to continue this discussion around telemedicine, but also around provision of services in underserved areas and in rural areas. Reimbursement is still a challenge, and so we think this is an opportunity to continue to explore those reimbursement challenges. As Dr. Huckfeldt mentioned, our graduate student here is looking into that future, so we look forward to that as well. We also really encourage those who are in this space of telemedicine to be publishing their findings and doing more research and rigor around this. With more research, I think we'll have a better understanding of the outcomes and implications of telemedicine. And we particularly would like to engage in a discussion with CMS. For Medicare, there's quite a bit of wonder or concern of whether or not we are able to provide equivalent services with telemedicine. And so if this study and others in the future are able to help establish equivalent or at least non-inferior care in areas that are truly underserved, how can we continue to support models, innovative models that could bring access to care?
Great, and I think that's all we have. So we'll open it up to questions. And I see the first one on here. I'm going to give this to Jerome, but if you go back to some of the qualitative research that we pushed out, 64% of our physicians were saying that telemedicine is a good mode of care.
Yeah. So, well, let's say keep in mind that there's 14 of them, and this survey was done in an early part of our history. I would say the first few months we were still troubleshooting technological issues. There was one site where the internet would go out or it was slow, and we had to troubleshoot those. I think in general, physicians really still prefer in-person visits. You can't touch a patient. You can't hold their hand through it. You can't wipe their tears, or you can't put your arms around their shoulders. And so to the extent that we can perform well with medical things, I think people are really happy with it because we know that we are providing a service and we have great purpose in the way we deliver care to rural areas. But is it the very best way to deliver care? I think our docs really want to be there right at the bedside, but we know that we can't always do it.
So at this time, we'll open it up to questions for any of our panelists. Just remember to type your question into the Q&A box on the right side of your screen, and we'll get through as many questions as we possibly can with the time we have left.
Conditions and specialties are most likely to integrate telemedicine in practice?
Oh, they can't.
Yeah, so the question was, what conditions and specialties are most likely to integrate telemedicine into their practice as one of the modalities? And so, our work that use the Minnesota All-Payer Claims database suggests that overwhelmingly, the most common use is for behavioral health, which I think makes sense because it is a field that is maybe less, needing a physical exam. So it kind of makes sense that, a remote interaction can be sufficient. Oh, and then there is this question: what's in the future? So, yeah, that might be I would maybe ask Jack and Jerome to prognosticate on that.
Well, I would definitely say that mental health, behavioral health is only going to grow. I think that we have we have a severe shortage of services, not even, but and we're talking about urban areas, but in rural areas it's even more dramatic. I also saw some work on the opioid epidemic and using telemedicine, telehealth services to help in that space. So I think that that's an area that's going to grow. Another area that we've been considering, but also I've been researching on, is the space of palliative care and hospice, so that there are more access points for individuals who could benefit from those services, where we're not always able to reach, especially given transportation issues in areas that are more remote. So I think those are some of the areas beyond what we already know within the different medical specialties.
Which one is that? Oh, that's a great question. So the question was whether we're aware of telemedicine use with hospitals in developing countries. And I do not know the answer to that question, but it seems like a very innovative use. I mean, it sort of parallels, in some countries, we have, in the rural U.S., we have shortages of primary care and specialty care, and some of those issues may be even more pronounced in kind of lower income countries. So I think that's a great question for future work.
I actually think there is some consultative work that occurs with telehealth and developing countries, but to the extent of reaching individual patients, I'm not sure. I do see a question about whether we use advanced practice clinicians in our hospice program. Currently, we do in our program. We don't in telemedicine. Our program is new. We actually are really excited to try to introduce more advanced practice clinicians in our telemedicine program. We think, though, that when we were first introducing it to communities that were new to telemedicine and to hospitals that were new to telemedicine, there's always a lot of concern and suspicion. So to the extent that we could alleviate some of those worries, we are currently using physicians only, but we have a sizable practice with advanced practice clinicians who are just excellent, and they're also very innovative and engaged, and so we would love to eventually incorporate more advanced practice clinicians into our program.
I think we have to get to the question that Henry put in. He's a current student here in the MHA program. He wonders if any of our panelists have advice for implementing multi-specialty ALS telemedicine care within academic medicine, which will help inform his advanced problem-solving project, his capstone project. Silence. Thoughts?
Henry, we look forward to seeing your final problem-solving report. We're not helping you. Let's see, is HealthPartners looking at unique partnerships with other organizations in this space providing telemedicine services? I mean, I think there is a lot of opportunity for growth in this space, and our hope as we start our program was to start somewhat small so that we can study it and understand the true impact on care before we go too fast. But I think as we continue to look forward into the future that there is a ton of opportunity, and there are more players coming into this space.
Yeah. And we have been approached by other systems to get advice and to do site visits and learn more. And we have always been open to sharing. We like to share. We think that it's better for our health systems and ultimately better for our patients if we share. So we have always been open to sharing. So if anybody is interested, we're happy to help.
Well, thank you to our presenters today for sharing your knowledge and expertise with all of us. Thank you for your participation, and I'd like to encourage all of our attendees to complete the survey about this webinar that will be sent out later today. Thank you again, and I hope you have a great rest of your week.